Welcome to today's webinar, A Step Forward in Understanding and Treating Myotonic Dystrophy Type 1. We're really glad to have this webinar today, especially as it is International Myotonic Dystrophy Awareness Day. And so with that, I am so pleased to welcome Dr. Dumont and Dr. Duchenne in terms of presenting this work. This is really recent in terms of we've seen it in the media, and it's really captured many of patients and family members who've seen your work highlighted, the most recent research, and they've contacted us at the research hotline. So I wanted to extend the invitation to both of you to present, and I appreciate you accepting. You both have been exceptional researchers, early career researchers, and also really exceptional in terms of your contributions with the Neuromuscular Disease Network. Before I pass it over to you, I actually wanted to share a few comments that Dr. Gagnon, Cynthia Gagnon, has shared on when we promoted this webinar, and I thought she set the stage really well. She called you both an amazing duo that has dedicated their research to better understanding myotonic dystrophy and are rising stars among young investigators. She said that it was a do not miss webinar, and she feels like this is representing translational science at its best. And so with that, I'll pass it over to you.
Okay, thank you. So thank you for the introduction. So I'm Élise Duchesne. I'm a full professor at the Université du Québec at Chicoutimi in the province of Quebec. So I'm also a research member of the interdisciplinary group working with neuromuscular disorder, which is led by Cynthia Gagnon. So it's a real pleasure for me to be here today on that special day for myotonic dystrophy, and also to be present with my colleague, Nicolas Dumont. So Nicolas, do you want to introduce yourself?
Sure. So pleased to be here too. I'm Nicolas Dumont. I'm an associate professor at the University of Montreal, and I've been working on different muscular disorders in the last few years, and with more and more interest on myotonic dystrophy. So I'm pleased to share today our work with Élise that was recently published, and that opens the way to better understanding and treatment of myotonic dystrophy. So Élise, I'll let you start, and I'll catch over on the second part.
Yeah, perfect. So today, just before discussing our recent result, we have a quite packed agenda. So the objective of this webinar were broad, large. So I will do the first part of the presentation. But Nicolas, don't hesitate to jump at any moment. So I will first present what is myotonic dystrophy type 1. I will present what therapies are in the treatment pipeline for this disease, what is the current clinical trial landscape for DM1. And I will finish this first part with a kind of summary of how my expertise, the expertise of my group, and can be combined with the expertise of Nicolas to be able to develop some new treatment related to DM1. And thereafter, Nicolas will take the lead and will present the importance of skeletal muscle tissue formation in DM1, the role of senescent cells in DM1. I will present what is the future for research in DM1, and it will also say a few words on a success story. So regarding myotonic dystrophy type 1, so sorry, I just try to, okay, now I see my screen. So it is the most prevalent adult onset neuromuscular disorders in Canada and worldwide. And more specifically, it is an autosomal dominant neuromuscular disorder. That means that if the mother or if the father is affected by the disease, the baby to born will have one chance out of two to also be affected by the disease. There is also a phenomenon that is called anticipation, which is present in this disease. And this phenomenon is if the mother is responsible of the transmission of the disease, the baby to born is more likely to present a most severe form of the disease. So this phenomenon is documented, but it's not really well understood at this moment. Regarding the prevalence, so it is established between one person affected out of 2,300 in the US, in comparison to the international prevalence, which reach one person affected out of 8,000 people. This prevalence is much higher in the region of Saguenay-Lac-Saint-Jean. It's the region where I live, where I work, and the prevalence is 16 times higher. So 1% out of 500 is affected by the disease, and this is due to a founder effect. So DM1 is caused by a CTG repeats in the DMPK gene. So in healthy people, so here, oh, sorry, there is a French sentence here. So healthy people will have between 5 and 37 triplet repeats, and this is absolutely normal. But if this number reach 50 repetition or above, this is considered as abnormal, and this is the way that the disease is diagnosed. So this number can reach more than 2,000 repetition. Unfortunately, there is a small to moderate relations between this expansion size and the severity of the disease. So it's not all due to the CTG repeat expansion. So DM1 is a complex, has a complex pathophysiology, and in addition to the phenomenon of anticipation that I just discussed before. So more precisely regarding the pathophysiology, so this CTG expansion of the MPK gene lead to CUG expanded RNA that contains all the CTG repeat. And this RNA will adopt an hairpin RNA foci formation, and this will lead to the sequestration of an important protein, which is MBNL1. And this protein is our RNA binding protein. And this sequestration will lead to RNA missplicing, and this will lead to symptoms that are documented in DM1, such as myopathy and fatigue. So for the phenotypic classification, there is 5 categories that is accepted by the field right now. And those categories are based on CTG expansion and also on the age of onset. So the late onset, the diagnosis will be done around 4 years old. Adult onset, which is the most frequent form, the diagnosis will be done between 20 and 40 years old. The juvenile onset between 10 and 20 years old. The childhood onset, also called infantile onset, the diagnosis will be done between 1 month and 10 years old. And the congenital onset, which is the most severe form, the diagnosis will be done between the neonatal period and 1 month. So the decreased life expectancies depends on the phenotypes, and phenotypes obviously will strongly influence the management of the disease. So DM1 is a multisystemic disease. So it involves impairments in the CNS, in the ocular systems, respiratory and cardiovascular systems, immune systems, and endocrine systems, GI system, reproductive systems, and of course, muscle. Skeletal muscle is severely impaired, and muscle weakness and atrophy are some of the clinical hallmarks of DM1. And those symptoms, for example, muscle weakness is a main contributing factor of physical limitations. And those physical limitations, namely those related to mobility, will affect DM1, the social participation of DM1. So skeletal muscle impairments negatively affect the individual in participation and in with physical limitations. So what are the therapies that are in the treatment pipeline? So regarding this kind of approach, which is pharmacological, so many strategies are currently tried to treat DM1. So some strategy target the transcriptional silencing here. Other try to target the post-transcriptional silencing. Other strategy aim to inhibit the interaction between the MBNL1 protein and the toxic mRNA. And others try to target pathways downstream the RNA toxicity. So I provide here a very good summary of what is currently ongoing in the field regarding the pharmacological approach. So you can see here the different stages. So preclinical study, phase 1, phase 2, phase 3, and pharmacovigilance, so phase 4 studies. And you can see the main outcome that are assessed by those studies. So they are outcome related to the root cause disease, such as DNA expansion, the RNA hairpin formation, the interaction between RNA and MBNL1 protein levels, alternative splicing, and other outcomes that are more specific to the disease, such as insulin resistance, myotonia, pain, CNS issues, and aging. You can see at the bottom of the figure the strategy that are used. So some are related to the use of small molecule, other rely on nucleic acid therapies, namely ASO, and other target the genomic and transcriptome, use the genomic and transcriptome engineering. Also, the Myotonic Dystrophy Foundation has published earlier this year a summary of where the pharma are right now. So there you can see here the different phases of clinical trial. For each pharma, you can see the modality that is used and the drug target or mechanisms that is used by the pharma. So I know that last week at the annual meeting of the Myotonic Dystrophy Foundation, some of those pharma present new results. So I'm sure that this table will be updated very soon, but I think it's a good reference to consult to be updated on this development. I just put here the website, so this website will be updated soon, so you will be able to consult it. So I just discussed about different strategies to treat DM1, but in the meantime, many efforts are put towards the development of a clinical trial to try the rehabilitation approach. So for the next minute, I will present some studies that are currently done in our research group regarding the rehabilitation approach that can be done for treating myotonic dystrophy type 1. So I will focus on two clinical trials that we work with during the last 5 years. So those clinical trials aims to evaluate the effects of a 12-week strength training program in men and in women with myotonic dystrophy type 1. So in those two clinical trials, so basically the people came to the gym 2 times a week for 12 weeks. And at each session, they did 3 series of 6 to 8 repetitions of 5 lower limb exercise. So the strength training was supervised by a physical therapist, and people were assessed at the beginning of the training at the middle of the training, at the end of the training program, to see the effects of this intervention. And we also reassess all the participants 6 months after the beginning of the training program and 9 months after the beginning of the training program to be able to evaluate the maintenance of the clinical gains induced by this intervention. So at each time points, we assess muscle strength, functional tests, self-reported questionnaire, and neuropsychological assessment. And importantly, we did muscle biopsy before and after the training program. So some results with the men cohort are already published, and the result for the women cohort are in writing right now. But for the men cohort, we were able to demonstrate that this kind of training effectively alleviates skeletal muscle impairments, and also had a clear impact on neuropsychological health of the men cohort with DM1. So based on those very positive results, we next try to determine the underlying mechanisms of this muscular positive response to inform drug development. So here is some recently published paper related to this men cohort that trained for 12 weeks. So we were able to demonstrate that this training rescue mitochondrial defects and also rescue transcriptomic defects. And we were also able to identify biomarkers for muscle function at proteomic level. So how can we help? So I will try to summarize the way that my expertise, the expertise of my group can be combined with the one of Nicolas. So one model that is very interesting for developing new treatment in a disease is the translational research. So it's in French, but I'm sure that you will understand. So there is two ways to do translational research. The first way is starting from patient and go to fundamental study. And the other way is starting from fundamental study and go back to the patient. So my group is very good, I think, to do the first way. So starting from the patient and go to the fundamental study. And one key point of this success is the high prevalence that we have in the region where we work, so Saguenay-Lac-Saint-Jean region. So for example, for carry out a training study, a training program, this kind of study design involves that patient have to go to the gym 2 times a week. So they have to live close the gym. And it's possible in the Saguenay because there is almost 500 patients that live within a 100 kilometer radius of the clinics. So it's easier for us to carry out this kind of research projects. And another very important element, it is that way before my arrival, so I arrived in this field in 212, but before me, there some very important research was conducted by Professor Cynthia Gagnon, and she worked on the establishment of the biggest natural history study in DM1 worldwide. So in the beginning of 2000, they assessed at multisystemic level 200 participants with DM1, and they were interested to see the progression of the disease across the time. And so based on this very solid protocol, we carry out many other projects, but for each project, we have same kind of guidelines. So one of these guidelines is to capture outcome measures that are related to the multisystemic nature of the disease. So even if I work with a strength training program, I always keep in mind that this can have effect on fatigue, for example, or on apathy or hypersomnolence. So we try to always use as much outcome measure as possible to capture the wide effect of an intervention, for example, or to capture all the elements related to disease progression. One other important guideline is to work with validated outcome measure. So Cynthia Gagnon is the world leader in the workshop that have been held in 4 times for selecting and validating the outcome measure that must be used in DM1. And we also have another guideline is to work with outcome measure that have documented meteorological properties, and if not, we work to document the meteorological properties to be sure that we work with valid and reliable tools. Another thing is that when we work with tools, we develop standardized operating procedure to be sure that they are followed very well by every health professional that use it. And so we recently validated this by our interdisciplinary team, and we pilot tested most of them in a cohort of more than 100 neuromuscular patients. This is just an example of a standardized operating procedure that we work with. And another important thing, and this is a key element for the development of collaboration, is that related to the solid phenotypic data that has been collected across all the study, we also collected biological samples. And since my arrival in 2012, we began to collect muscle biopsy. So this allows us to have a more complete portrait of the participant and be able to work in a transitional way. So this is the part where we are not that good, is to start from fundamental research to come back to patient. And we strongly believe that this part of translational research is very important. And that's why we need to collaborate. And this is the way that the collaboration with Nicolas began. And he will explain you which project that we built together. But one important thing I think in this kind of development of new treatment is to be able to have the whole portrait of the participant. So the fundamental part combined with the clinical part. So Nicolas is my friend from the last 20 years, so it was easy for us to start this collaboration. But I have to say that I am very fortunate because Nicolas is a very good researcher. So he just won the Early Career Biomedical Researcher of the Year this year. So I'm very fortunate to work with him. And also the field is fortunate to have it because his background is in Duchenne muscular dystrophy. So I am proud to convince him to work with DM1. And I will let you the floor, Nicolas, for the rest of the story.
Great. Thanks a lot, Elise, for this very nice first introduction and very nice covering of the first part of the talk. And as Elise said, we've been friends for quite a while. And if we can go back to the previous slide, we can clearly see that. That this comes back from a while. We can even see with the TV just down in the back that it's not a flat screen. So it's been quite a while since we worked together, and we got both our expertise in different ways. And now it's good to be back and working together. So yeah, we can move to the next slide. And one thing that I think that is that was interesting for this project, and when Elise came to me a couple of years ago to discuss about DM1, how it would be interesting to dig a bit more into the fundamental cellular biology behind the disease, is that we are at Saint Justin Research Center, and there we have a brand new research center that has been equipped with quite a lot of different platforms that could be very useful to really go into the fundamental basic of the disease. We have gene editing, we can do single cell sequencing, spatial transcriptomic, mass spectrometry, drug screening, high resolution microscopy. So we do have a lot of tools that we can use to really push forward the science in this field. And that's a bit what we did in this first project on DM1. If we move to the next slide. And what we focused on for this first project was a bit of the idea of Elise, which was that we probably had something to do related to muscle formation and regeneration that could be impaired in myotonic dystrophy type 1. And there was not much known at this time about this defect in the disease. So we decided to focus more on that first aspect. And what did we focus on is actually the muscle stem cells, which are very important for muscle growth after birth and also for muscle regeneration. So when there's an injury, muscle is able to regenerate, and that is due to the presence of the muscle stem cells. So if we can start the video, which is, yeah, we can see here a muscle fiber that is responsible for the contraction, but there's a small muscle stem cells on top of it that will start to get activated, and we can see it divide the first time here, generating 2 muscle stem cells that will eventually divide again to generate 4 cells, and then 8 cells and 16 cells. And when there's enough of these cells, they will start to fuse together and reform a new muscle fibers. And this is really the cause of muscle regeneration, and that is the thing we focused on, that because that could be impaired in myotonic dystrophy. So that's what we set out to look, and we were lucky enough to have Elise and all the thing that she presented in her biobank that she generated over the years, and she managed to recruit in a matter of weeks 10 patients, and as well as age and sex match LT controls, and take muscle biopsies out of these individuals. So that's actually, for me, it is just amazing how they are well organized to collect these samples, and how patients are really involved into research, especially in such a rare disease. And with the muscle biopsies, then we wanted to make the best out of it. So we use for different aspect the muscle. So we cut different sections, and we use some for molecular biology, some for immunostaining and microscopy, and some of them also was collected to isolate the muscle stem cells, which we could then use to culture in vitro and do different experiments. Next slide. The first thing actually that we did with the muscle stem cells was to do single cell RNASeq. So with this technique, we are able to look at the gene expression of every single cell. So the graph that you see on your top left, you can see the cells in blue, which are cells from the controls. So every little dot is muscle stem cells from control patients. And in red, you'll have the cells from the DM1 patients. And we can analyze these different populations. And what we can see, if we look at the biological processes that are differential between the cells from DM1 patients and the cells from the controls, is that we have a very strong signature of immune signaling and cellular senescence. And cellular senescence is actually a state where the cells stop proliferating, so they become completely out. They're not able to proliferate and contribute anymore to muscle regeneration. And one of the consequences of this is that they send signals, inflammatory signals, to the neighboring cells. and that could affect actually the whole system. And that signature, actually, if we looked carefully, we can see that it's really related into a small population of cells. So if we can click again, you'll see on right here in the red circle, that subpopulation that really expresses strong immune signature, expressing a lot of cytokines and factors that is really characteristic of cellular senescence. Next slide. We can see here, so that we wanted to make sure that this was actually cellular senescence. So we perform more analysis on the different subset of cells. So this is only the cells from the myotonic dystrophy patients. And when we do bioinformatics analysis on these cells, we can see that we have different clusters. So we have cells with different genetic signatures. And we compared this signature to what have been published by other groups in the field regarding cellular senescence. And what we can see on the heat map is that there are subgroups that express no cellular senescence signature. These are the group with the blue in the heat map. So that there's no really signs of cellular senescence. And there are other subgroups that are actually expressing high level of cellular senescence. So the groups in red express genes really related to this biological process. And there's one subgroup that is kind of in between, expressing some signs of cellular senescence, but not the high expression of inflammatory cytokines. So we decided to rename these groups. So if you can click again, we can see at the bottom here, we rename the groups depending on the cellular senescence. So in green, you have the non-senescent cells, so cells that are healthy. The transcriptional profile looks normal. The ones that are in yellow, gold are the ones that are early senescent, have some sign of cellular senescence, and the ones that are in purple are really with the high senescence profile. So based on this, we decided to dig a bit more to understand what are the contributions of these senescent cells to myotonic dystrophy type 1. So first thing to be really clear about what is cellular senescence is state of the cells when they receive a stress. It could be a stress from irradiation, could be a stress from a physical stress, could be aging. There's different types of stress that could, chemicals or drugs could also induce this kind of stress. And that will lead to a damage in the cells that will stop proliferating, that will become senescent. And then the senescent cells will send signals to the neighboring cells saying, well, I'm in distress. I need usually for the immune system to clear that cells. But these signals, these inflammatory signals, will affect the neighboring cells, and that could lead these cells to become defective also and to send more signals that we call the SASP, the senescence associated secretory phenotype, and that could lead to a global systemic effect that will affect the entire system. So we continue looking at cellular senescence in DM1. And we had the transcriptional signature that was saying us that there is a cellular senescence signature, but we wanted to make sure that it was the case. So we did perform different staining with different markers. One of the classical one is the cellular senescence associated beta-gal staining. That is strongly upregulated in the cells of the patients when we culture them. So we see a strong upregulation, about tenfold in the number of senescent cells when they're in culture. There are also cell cycle inhibitors that are classical markers of cellular senescence, just as P16 and P21. And in this case, P16 was especially upregulated. And also, if we let the cell proliferate and we look at their cell growth over time, we can see that the proliferation of the DM1 group in red, the curve is lower compared to the controls, so that we really have clear signs of cellular senescence when the cells are in a dish. But there's a difference between having cells in dish that are senescence and having cells in the muscle that are senescence. And we wanted to make sure that it was not actually just an in vitro artifact, that could also be found in vivo. So we had the muscle biopsies. So we decided to do sectioning and do staining and microscopy on these samples. And we found out that these cells actually also express, the muscle stem cells in the muscle, also express cellular senescence markers such as P16 expression. So there's about a 5-fold increase in these number of cells. And the RNA expression also of P16 and P21 is also increased in this group. So there's really upregulations of senescent signs also in the muscles. So then we wanted to see, is there a direct correlation? What is causing the cellular senescence in DM1? Because in other type of disease, such as cancer or irradiation or different drugs, we know what could be causing the cellular senescence. But in the case in DM1, we hypothesized that it would be due to the toxic RNA accumulation in the cells that would be causing the cellular senescence. So to have a closer look at this, what we did is to count the number of RNA foci that are in the cells. So when that toxic RNA accumulates, it forms these small red dots foci that we can see in the staining here. And what we did is to compare the number of foci per cells that are senescent versus non-senescent. And what we can count here is that there is more accumulation of RNA foci in the senescent cells, which would suggest that the more RNA toxicity that accumulates in the cells, the more likely it is to become senescence. So that would be the cause of cellular senescence in DM1. Next slide. And then the main effect of cellular senescence, apart from the fact that cells stop to proliferate, is that the cells actually express a lot of cytokines in the environment, what we call the SASP. And to look if that could have an effect in DM1, we did conditioned medium experiments where we take the medium, culture medium from control cells or DM1 cells, and we put that medium on healthy cells and see what happens. And what happens actually is that when you put DM1 medium on healthy cells, is that the cells will proliferate much less efficiently, and they will also differentiate less efficiently. So that there's something that is secreted by the cells that goes into the environment that will impair the myogenesis of the other cells that are neighboring in the environment. So that is really a classical signs of SASP that affects the neighboring cells. And what was very, very nice actually with the collaboration with Elise is that it's not only that we move into the more and more fundamental biology and say, well, we find SAS and biomarkers, but we can also go back to the patients. And Elise really said it well when she said that they created massive cohort where they followed in time and took different outcomes at different time points that are highly standardized. And that was so useful for that project because we were able to see if the findings that we had on the cells, could we translate it back to the patients. And one of the things that they did in the past was to collect blood samples from patients, from over 100 patients, which is absolutely amazing. And they did physical tests on the same patients so that they measured muscle force of different muscle groups from the upper limb, lower limb, as well as different physical tests, walking speed, and these kind of things. So what we could do with this is that we can go back and look if the markers that we found, the inflammatory markers, especially of the SASP, could we use that as a biomarker to verify if that correlates with muscle strength in the patients. And one of the markers that is actually upregulated in our data sets is the interleukin-6, which is a well-known inflammatory cytokine that is well-known actually to be expressed by senescent cells in the SASP. So we decided to look at the correlation between IL6 and the force, the strength of the patients, and actually we found the negative correlations with pretty much all the outcomes that were measured. Here it is for the lower limbs, so the different muscle strength of the ankle, of the hip, of the knee. The higher the IL6 level is, the lower the muscle force of the patient is. And that was for the lower limb, but we get the same results for upper limb. We get the same results for functional tests. So that's a really strong signature of IL6. But for other markers such as TNF-alpha that are not upregulated in our data sets, we found actually no correlations with the patient's strength. So that there's really a strong correlation with the results of our single cell RNA-seq data sets and the clinical findings that we get in the patients. So where do we go with this? Is there, we identify new mechanism of the disease, but can we use this as a potential therapy for DM1? So that the next step we aim to focus on this project. And luckily, there's been over the recent years different drugs that have been developed to target senescent cells, which we call senolytics. So these are drugs that aim to eliminate the senescent cells so that you only get the good healthy cells remaining. And there's these different approach target different pathways. Different drugs target the AKT pathways, that will target the BCL pathways, that are p53 pathways. These are all survival pathways that are important to maintain the senescent cells in this kind of zombie state, so that it doesn't die, but it's not really useful and contributing anymore. So these drugs try to target these pathways to help to kill the cells, basically. Next slide. Yeah, so we weren't sure which compounds could be useful, because the efficacy of the senolytics varies very dependently on the cell type and the type of stressors. So we decided to screen for a couple of them and see what was working best. Here in the graph is the efficacy of the drugs on the controls and DM1 cells, and actually most of these drugs actually were toxic for both controls and DM1 cells. So they were not specific to eliminate the senescent cells. It just seems to target pretty much all the cell types. But if we click, we can see that we found one lead compound, which was the A11-55463, which is a complicated name, but it's a Bclx inhibitor. And we can see in this graph that actually when we treat the cells with that drug, we eliminate the senescent cells in DM1 without affecting the healthy control cells, so that it seems to be specific for the DM1 cells. And this fits very well with the results that we get for the BC from our single cell RNA-seq, showing that this pathway, the BCL pathway, is upregulated in our senescent cells compared to the healthy cells. So it seems to be very strongly correlated. Then we aim out to confirm that it was actually eliminating the senescent cells. So we performed again our senescence-associated beta-gal staining. So we can see that the treatment actually removed the senescent cells. And more importantly, if we measure all the SAS factor, all the different cytokines that are expressed by the senescent cells, we can see that the senolytics reduced pretty much all the different cytokines that were upregulated in our single cell RNA-seq data sets. So that we not only remove the senescent cells, but we remove the SASP, so that could help to restore normal myogenesis. And that is actually what we did in the last step, which is to see if we can restore normal muscle stem cell function after the treatment. So we treated control cells and DM1 cells with either controls or placebo or the senolytics. And what we can see is that when we treat the cells with the senolytics, they restore their capacity to proliferate, as marked by the Ki67 proliferative marker. And we also restore their ability to differentiate, as shown by the marker myogenin, so marker expressed by differentiated myogenic cells. So that removal of the senescent cells reduce the SAS, and then the other cells that are surrounding now feels better, and they're able to proliferate better and differentiate better. And this was actually quite a complete story, but it's actually something that was where everything came at the right time with the right people. So if we can see on the timeline here is that we performed that project in actually 4 years from the idea of the project to the publication, which is in this field actually in research is actually quite rapid. From having the idea of Elise saying, well, you should have a look into this into this DM1. I think there's something interesting, and then getting the ethic approval, getting the funding, because actually we need some funding to start the experiments, recruiting the patients, which was done so quickly, getting the samples, recruiting the students, which was hard work, especially by Talita Kante, who did an amazing job with this project, and also Ines Makhtari that helped her quite a bit with this. And that was also course supervision between me and Elise, so that we really had a nice interaction between our groups. And despite the fact that it was COVID that struck at that moment, students worked very hard so that we can get preliminary data, get a bit more funding, keep working and advancing this project, so that in a couple of years we were able to submit the papers and get it published recently in the Nature Communications. And what is very interesting about this project and about this collaboration especially is that we usually in my lab, we move from the fundamental to the clinic, contrarily to Elise's lab that do the opposite. So usually we move from cell biology to modeling to trying to do drug screening, personalized medicine, and then we move into preclinical model of usually mouse models of the disease, and then we try to move that to the clinical trials. But actually in that project, move kind of the other way around. If we click, it actually started from the patients with the idea that there was some deficit, and we had some samples from the patients, and then we can move to the basic biology. And then if we click again, we can see that we are coming back sometimes with the patients, so that we found this inflammatory signature. And so we said, well, okay, that maybe that has an importance in the clinical settings, so that we can go back to the patients and say, okay, that could be used as a biomarker for the disease, so that we know that it's relevant to the disease, and then we can do this back and forth between the fundamental biology and the clinical one. And what is also very nice about this project is that it's actually just the beginning. We have much more idea. The better we understand the disease, the better, the more it gives ideas to pursue different projects, different therapies. So that really set up the foundation of a full research program on DM1. That allowed us to secure major fundings from different agencies such as the AFM, Téléthon in France, and the CIHR in Canada, so that we can pursue these experiments in this project. Also allows to generate high quality data sets. So from the very well characterized muscle samples, different time points, different groups, very well characterized patients, we are now able to perform different analyses at the proteomic level, lipidomic level, transcriptomic level, and then we can correlate that with the clinical findings. And I think that's going to be very useful for the field to rely on these well characterized data sets. And that's also allows us to establish networking partnerships so that we can move this actually towards clinical trials. And I think that is pretty much it. So you can see here all the people involved in this, so that there's my group, there's Elise's group, there's all the collaborators involved, so that it's really a big team effort to so that we can move these projects forwards. And I'm really thankful for to everyone that has been involved in this project.
Wonderful.
And how we can take
questions. No, I appreciate it. This is great, especially I can't emphasize this enough on International Myotonic Dystrophy Awareness Day to see such potential and exciting collaboration and these results. A common question that I am seeing in the chat is this is as we alluded to with the webinar title and as was in the media, this is a major step forward for DM1 research. How close are we, however, to a drug coming to clinical trial or coming to patients in terms of accessing a drug? How close are we?
Ladies, you want to start?
Yes, I can. Yeah, that's a good question, and we only can partially answer that question. So one major thing in our work is that we kind of discover a new mechanism of action. So this is pretty new. So and for the clinical trial, except for the COVID, which was very, very, very fast, but normally it's not that fast. But the good news with our project is that senolytic is already used in another kind of diseases. So that's why it can be a promising therapeutic avenue for DM1. So, but for the right time frame, it's very hard to predict at this moment because there is some steps that need to be done. For example, we assess this in skeletal muscle tissue, but we need to see if senolytic is toxic for other system, for example. So there is a lot of clinical data that has to be collected regarding the pharmacodynamics of the drug and also the tolerability and the safety of the drug. So I don't know if you want to continue, Nicolas.
Yeah, sure. Just to add on this, what's also interesting with the senolytics is that there are other groups that are coming up with the same kind of results as what we have. So one important thing in science is the reproducibility of the findings, so that independent groups validate that it could be a good approach. And actually, there's two other groups that kind of comes with the same results using different models, so that it really pinpoints that cellular senescence is a real thing in DM1 that has actually importance on the disease progression. So that could accelerate the findings. And as Elise said, we can repurpose some drugs that are already in clinical trials for this drug. So that could speed up a bit the process. But in the end, that might be a drug category that could be used also maybe in combinations with other drugs that are already in clinical trials and could already be eventually used for the patients, because that targets a different pathways, so that maybe that could be used in combination eventually to help out to improve the clinical effect. But yeah, right now we're in the validation of in the animal models, so that we can make sure that it affects all the systems and also works well in vitro in this context, in vivo in this context.
Wonderful. Another question here is: was there an overall upregulation of satellite cells in DM1 patients and impaired myogenesis?
In the patients, from what we see, I would have to look back at the data, but I think there's a downregulation mostly, at least in the mouse models. I don't know if we measured it in the human, the number of muscle stem cells per muscle. Did you do it, Elise? I don't recall.
Yeah, I already did it in another project, and what we saw is the number is increased. So the proportion of a PAC set positive cells is normally between 2 to 5%, but in the DM is increased around 15 to 20%. So the number is increased, but we didn't look at the function of this increased number right now. So, but for in the absolute, this relative aspect, so yes, it is increased.
So it could be because they're activated, or when they become senescent, they accumulate in the tissue. So the functionality will be important to assess in this.
And do you think the upregulation of IL6 is due to SASP, or is it simply chronic systemic inflammation due to inactivity?
Probably a bit of both. I think IL6 is a classic marker of SASP, we're looking into what are the cellular source of this IL-6 by performing different experiments, such as RNA fish, so that we can see who's secreting that IL-6. But I definitely the muscle stem cells express it. Are they the main source? Hard to tell. We also have to keep in consideration that cellular senescence probably affect other tissues in DM1 because all the systems are affected. So it could come from other senescent cells from other tissues also. So there's probably different sources.
You know, a couple of questions here are, so as Elise you mentioned, this is a multisystemic condition, so it affects multiple systems. And this is early translational research, but the questions are, would a drug like this potentially impact daytime sleepiness? Would it impact apathy? Hard to say probably right now, but what are your thoughts on those other impacts of myotonic on the body?
Yeah, that's a very good question, and I understand for a patient, it's you know, we work on skeletal muscle, so we were like, okay, there is a very clear effect on muscle, so that's good. But for a patient, maybe the main complaint is, for example, GI or is sleepiness or somnolence. So I agree that we have to keep it in mind. So in that context, I think that our discovery, in a sense, it can be a wall effect, also a multisystemic effect. So it kind of positive in that way. But I think that we have to keep in mind that probably that the best drug will be used in combination with other drug or with life habits, such exercise, for example. So I think that the pharma are not very willing to go that way, but with the accumulating studies showing that, for example, training has benefit effects on cognitive aspect and on physical aspect, I think that they will be willing to consider that combination option.
I'll take one final question here, and it's repeated a few times, which is, how can people get involved, as in how can they share their own cells or participate in this research when it moves outside of the animal model, for example?
Yes, so they have to be, the ethic process is that I can only work with the people that are related to our neuromuscular clinics inside of our hospital. But there is a lot of physicians that work with patients with DM1, so they have to tell their physician that they want to be involved. And maybe I don't want to put you on the spot, Amira, but maybe that DMC or NMD4C can help with this to know which clinician are involved in research. And for sure, we could, for example, train physician to do muscle biopsy or share our SOP, standardized operation procedure, to be sure that at the country level, every participant that is a volunteer to participate to research can do it in their own hospital.
Excellent. So with that, we thank you both for a really clear and well-delivered presentation today. A really great way to mark International Myotonic Awareness Day. And thank you everyone for joining, and we wish you a good rest of your day and weekend ahead. Thanks everyone.